So today we'll be looking at coagulation disorders in pregnancy. Coagulation disorders in pregnancy. And we're going to just run through it and see some key areas that we may need to focus on. All right, by way of introduction, a pregnant woman with coagulation disorders presents a very unique challenge to the anesthetist. All right, these women include, some of the challenges include concerns for peripartum hemorrhage, the consequences of bleeding disorders, and strategy for clotting factor replacement, anticoagulation on the safety profile of your neurasia block. Note that part of the physiological changes in pregnancy is hypercoagulopathy, which results from increased numbers of clotting factors, an increase in total plasma levels, especially of factor 7, factor 9, factor 10, and factor 12. So all this makes pregnancy a hypercoagulable state. Just a little recap on coagulation. It starts with injury to a blood vessel, which leads to activation of platelets by contact with the injured endothelium and subsequent formation of platelet plug. Now, this leads to activation of coagulation pathway with ultimate generation of thrombin and fibrin clots, which attempts to stabilize the platelet plug that has been formed. All right, this either leads to healing and repair of the endothelial injury, and there's a balance between fibrinolysis and clot removal and the extension of clots by antithrombin mechanism. So this keeps the blood vessels patent, and this is important in coagulation cascade. All right, we remember there are two pathways in coagulation cascade, the intrinsic and the extrinsic pathway. We just go through this. I just felt I should bring this in for us to see, all right, just to remind us about the different pathways involved in coagulation. All right, the both intrinsic and extrinsic pathway meet at the common pathway, which leads to thrombin formation and balance between fibrin formation and fibrinolysis. All right, so let's quickly look at the hemostatic changes in pregnancy. Like I mentioned before, pregnancy is a hypercoagulable state, which results from either total or relative increase in different clotting factors. All right, in the table on the left side of the slide shows the different factors, hemostatic parameters, the factor 2 and factor 5. All right, prothrombin and factor 5, there's usually no change in their levels at term in pregnancy. Fibrinogen, there's more than 100% increase. All right, that's factor 1. There's more than 100% increase in fibrinogen levels. Factor 7, up to 1,000 increase. Factor 8, 9, 10, 12, and von Willebrand factor also increase more than 100%. The increase in factor 11 is variable. Factor 13, there's up to 50% increase. Protein C, there's not been any detectable change. Protein S, there's up to 50% decrease. And D-dimer, and this we're going to come to this later on, D-dimer levels increase up to 400% at time in pregnancy, while platelet count normally will increase up to 20%. Now, what are the etiology of coagulation disorders in pregnancy? All right, this can be divided into acquired or inherited disorders. The acquired can either be obstetrics or non-obstetric causes, and we're going to look at that as we go on. There are inherited coagulation disorders that may be present in pregnancy. like the hemophilia A, which is due to the deficiency of factor 8, hemophilia B due to deficiency of factor 9, and we have hemophilia C, which is a deficiency of factor 11. Von Willebrand disease is as a result of deficiency of von Willebrand factors. All right, so these are inherited, but we're going to concern ourselves more with the acquired causes of coagulation disorders in pregnancy. All right, in a broader view, acquired causes can actually result from endothelial injury, like I mentioned before, and some of the conditions that can lead to endothelial injury in pregnancy include pregnancy-induced hypertension, the eclampsia, HEP syndrome, septic abortion, chorioamnionitis, and hypovolemia. These can cause endothelial injury. All right, it can also result from release of thromboplastin into the blood, into the circulation, and this occurs more commonly in the conditions like amniotic fluid embolism, abruption placenta, molar pregnancy. Lower segment cesarean section can actually cause a release of thromboplastin, or when they give intraamniotic hypotonic saline and a shock disorders or shock states, this will lead to a release of thromboplastin, which can cause coagulopathy. All right, fetal maternal bleeds can cause a release of phospholipids, incompatible blood transfusion, and hemolysis. These are other causes of coagulopathy in pregnancy. So if I ask you to write a short note on the pathophysiology of coagulopathy in pregnancy, these are the things I want you to mention, both the acquired and inherited causes. Then I want you to talk about how the acquired causes can cause coagulopathy, as I presented in the previous slides. Now, let's look with this saying that coagulopathy in pregnancy can result either from obstetric and non-obstetric causes. All right, so we look at obstetric causes, preeclampsia and eclampsia. All right, this actually results from your thrombocytopenia, a decrease in antithrombin 3, which is in proportion to severity, and secondly to increased factor 8 consumption. Now, the more severe preeclampsia eclampsia is the more the coagulopathy that we ensure. Abruption placenta is the most common cause of obstetric DIC, most common obstetric cause of acute DIC. All right, premature separation of the placenta. Fetal death syndrome, all right, this is due to a leak of tissue thromboplastin from the decaying fetus into the maternal circulation. Other obstetric causes include septic abortion, amniotic fluid embolism, although the cause is unknown, but it may not be unconnected with the volume of the intravascular amniotic fluid itself, but much more is a result of the abdominal substances that are present in amniotic fluid. So it's not much of the volume, but the abnormal substances that you find in amniotic fluid, which leads to a cascade of coagulopathy. Others such as placenta previa, placenta creta, degenerative neomyoma coexistent with pregnancy, and molar pregnancies are other causes of obstetric DIC. Non-obstetric causes include antibiotics. Many more broad-spectrum antibiotics are associated with hypoproteinemia, and minority patients seem to be at high risk. So when you're giving antibiotics to patients who are malnourished, all right, this can predispose to coagulopathy, especially in pregnancy. Acquired inhibitors such as protein C and protein S, and the most common are actually the antiphospholipid antibiotics and the factor 8 antibiotics. These are acquired inhibitors that can predispose to coagulopathy. Other ones are the platelet disorders, which can either be quantitative or qualitative, all right? And an example is thrombocytopenia, which is defined as a platelet count of less than 150,000 platelet cells per microliter. All right, so in summary, summary of obstetric causes of coagulation disorders in pregnancy. I like to call it that pregnancy safe or safe pregnancy. All right, for us to just remember. But safe preg will help you. All right. S there refers to septic abortion. A talks about abnormal placentation, the abruptio placenta, placenta previa, placenta accreta. All right, others are antibiotics, both further antibiotics. F is where you have the fetal death syndrome. E, embolism, the amniotic fluid embolism. And the P is your preeclampsia or platelet disorders. So if you ask, list some obstetric causes of coagulation disorders, once you can remember safe pregnancy, you should be able to remember at least 3 or 4 of the causes of obstetric causes of coagulopathy. Yes, in pregnancy, a lot of us, I'm sure many of us would have managed or come across a case of DIC in pregnancy. All right, and we're just going to look more into it as we go on. All right, according to the International Society of Thrombosis and Haemostasis, DIC is defined as an acquired syndrome which is characterized by the intravascular activation of coagulation with a loss of localization arising from different causes. All right, the important thing is an acquired syndrome with intravascular activation of coagulation, all right, that occurs from anywhere, can occur from anywhere. And don't forget that it's a common cause of abnormal bleeding during pregnancy and even in the period. What DIC reflects in pregnancy is, the circulating coagulation, the activation of coagulation cascade resulting from circulating thromboplastic material, all right, which leads to secondary activation of fibrinolytic system. So there's a lot of hemorrhage and thrombosis that coexist in DIC. All right, I mentioned this before just to recap. So some of the common causes are the ones listed here for your consumption. All right, how do you make a diagnosis of DIC? All right, it rests on one, the finding of reduced level of fibrinogen and platelets. All right, there's prolongation of thrombin, prothrombin, and partial thromboplastitin. All right, and there's presence or increased presence of fibrinogen degradation products in the serum. All right, there's the use of point of care viscoelastic test. All right, the thromboelastograph and rotational thromboelastometry. The important thing to note here is that in pregnancy, thromboelastograph displays a shorter R and K values with a higher alpha angle. And what it means is that, clot formation is faster and bigger during pregnancy, especially during the 3rd trimester. So point of care, why this is important is that a lot of times, these other tests, coagulation tests may not be specific, but point of care viscoelastic tests have been found to correlate very well with DIC developing in pregnancy. So how do you manage in case of DIC? You want to treat underlying condition, all right? Prompt, fast, and prompt delivery or termination of pregnancy. And this, the best route is to be decided by both the managing obstetric team and the anesthetist, all right? Supportive treatment, these are general generics, all right? Supportive treatment with blood products, all right? Surgical care related measures. Then there's need for rigorous clinical and laboratory patient surveillance. One test is not enough. Repeated tests, all right, is important for us to be able to track DIC and manage it appropriately. Multidisciplinary team is very important. And this way, at the level of consultants, you need to get hematologists, your gynecologists, and obviously the anesthesiologist involved. All right, so this level of care needs to be activated as soon as a patient with DIC pregnancy presents to the hospital. One of the very important management of DIC pregnancy is the need to treat the coagulopathy. All right, there are different ways this can be achieved. Number one is the use of your antifibrinolytic agents. All right, the common example is the tranexamic acid. And what it does is it helps to prevent the activation of plasminogen by plasmin. All right, which blocks its lysine binding sites. All right, in obstetric hemorrhage that does not resolve by conventional treatment, you can give recombinant active factor 7. All right, and this has been found to also help prevent the need for hysterectomy in this patient. Experimental management, experimental care, with the use of human fibrinogen concentrates have been used, especially in cases of hypofibrinogenemia or dysfibrinogenemia, and even when there's no fibrin at all. So human fibrinogen concentrates have been used with success. All right, the analog of your vasopressin, the desmopressin 1-diamino 8-D-arginine vasopressin, increases factor 8 concentrations and cause a release of von Willebrand factor for endothelial cells. And all this helps to promote platelet aggregation and adhesion. Recombinant human soluble thrombomodulin has also been tried, and what it does is that it helps to reduce excessive thrombin activation and helps to regulate the imbalance of the coagulation system that is commonly seen in DIC. When DIC has a predominant hypercoagulation, all right, anticoagulants like your low molecular weight heparin can be used in this scenario. But note that it's important to know that low molecular weight heparin is superior to your heparin or fractionated heparin in this management. All right, this slide shows you a flow chart on how to make a diagnosis and manage DIC in pregnancy. All right, you want to be sure what are the obstetric risk factors for DIC in this patient. All right, is there acute postpartum hemorrhage, which may lead to consumption, coagulopathy? Is there history or presence of abruption placenta? Does this patient have preeclampsia or HEP syndrome? Is there retained product or retained stillbirth? Is there sepsis or intraamniotic infection? Is there presence of acute fatty liver? Or there is amniotic fluid embolism? So you want to first of all look at the obstructive factors. All right, if the answer here, and you want to find out, are there clinical diagnosis of DIC? Clinical, most of the time, DIC is diagnosed on clinical basis. And the demerit there is that a lot of time is diagnosed late. Okay, but if there are clinical signs of DIC, prompt treatment will include delivery of the patient as fast as possible. You want to give blood products according to your transfusion protocols. You want to look for the treatment or the line cause and treat it. Like I mentioned before, you want to engage in repeated laboratory testing and monitoring. Multidisciplinary approach cannot be overemphasized in this group of patients. On the other hand, if there's a presence of risk factor for obstructive DIC, but there are no clinical signs of DIC yet, you want to follow clinical laboratory evaluation. You want to consider the use of point of care testing, like I mentioned before, your thromboelastograph. You want to apply DIC score for risk assessment, which we're going to look at very soon. Now, if you do your risk assessment, your JSTH DIC score risk assessment and is high, more than 5, you want to immediately call a multidisciplinary team. You want to consider early administration of your blood products and supportive measures. and you want to ensure close clinical and laboratory surveillance. Well, if it's less than 5, your JSTH score, then you can just continue with close clinical and laboratory surveillance. Now, this is all I'm talking about, your International Society of Thrombosis and Haemostasis score for DIC. 4 parameters are involved: the platelet count, the prothrombin time, the fibrinogen level, and the D-dimer level. All right, so a result of more than 100 teres/9 per liter score the patient 0. The risk of DIC is 0. But if it's less than 100, the risk is 1. And if it's less than 50, risk is 2. If your prothrombin time is less than 3 seconds but prolonged, 0. More than 3 seconds but less than 6 seconds is 1. And if your prothrombin time is more than 6, the patient scores 2. Fibrinogen level more than 1 gram per liter is 0. Less than 1 gram per liter is 1. Your D-dimer, if there's no increase, 0. When there's a moderate increase between 250 and 5,000, you score the patient 2. When there's a strong increase of greater than 5,000 D-dimers in the serum, you score the patient 3. Now, a total score of more than 5 or equal to 5 correlates with DIC, but you must interpret this and the background of risk factors for DIC. However, in pregnancy, all right, there are some changes that have been made. And this is due to the changes in hematological changes that occur in pregnancy. Instead of the previous 4 parameters in pregnancy, we use 3 parameters. D-dimers have been excluded because, like I mentioned in the previous slide, the levels are actually very high, more than 400% increase, especially at time. All right. So for pregnancy, D-dimer is not scored in the JSTH DIC scoring system. So, but you can see here that prothrombin time is actually checked in response to in correlation with the standard. So if prothrombin time is less than 0.5, the difference is less than 0.5 is called 0. But if the difference between 0.5 to 1, the patient has 5 points. If the difference between patient's prothrombin time and the normal value, all right, 1 to 1.5, 12 points. But if the prothrombin time is more than 1.5 compared to normal, you give the patient 25 points. The same also here for fibrinogen. If it's less than 3, all right, 25, between 3 to 4, 6 points, 4 to 4.5, 1 point. And if the fibrinogen level is more than 4.5 grams per liter, 0. Note that a score of greater or equal to 26. All right, so if prothrombin time difference is more than 1.5, and you have a platelet count of between 50, the patient already qualifies for the diagnosis of DIC. So when you have a patient with coagulopathy or DIC in pregnancy, history and physical examination, which includes a complete bleeding history and physical examination, is important. You must always pursue any suspicious findings. Don't forget that based laboratory evaluation, like I mentioned before, the prothrombin time, the partial thromboplastin time, platelet count, and fibrinogen level should immediately be made available for interpretation. These are simple laboratory screening tests, all right? You know, the description is, the table is very important because it shows you the description, all right? If you are testing for coagulation, what you'll find is reduced fibrinogen. Prothrombin time, all right? There's increased prolonged prothrombin time, all right? Prolonged thromboplastin time, and you have reduced fibrinogen. Platelet count is not, the absolute count is important, but much more than that is the function. You can have adequate platelet count, but reduced function. That's why we talk about the quantitative and the qualitative value of your platelet count. Fibrinolysis, which is described in terms of increased fibrinogen degradation products, all right, it's very important. But remember that the interpretation may be skewed in pregnancy. All right, you can use a euglobulin clot lysis time to assess your accelerated clot lysis. So this is a simple table to show you the simple laboratory screening test that you must order for in the face of DIC pregnancy. All right, other simple tests can be done. You can do a clot observation test, especially if you are working in a rural area or you are pressed for time, laboratory is not giving your test result immediately. You can do what we call clot observation test. We draw 5 to 10 ml of blood in a test tube and observe for clotting. It should clot normally within 10 minutes. All right, the other one is you can withdraw 0.5 ml of fibrin des, which contains thrombin, added to 0.5 ml of plasma in a test tube. In 5 to 10 seconds, you must see visible clot. All right, delay clotting up to 30 seconds or no clotting at all is associated with BIC. These are simple tests you can do in the OR, especially when you are faced with suspected cases of DIC. The Snyder test, you get thrombin is added to a serial dilution of patient's plasma. All right, you keep increasing it 1 to 2, 1 to 4, 1 to 8. You can get as high as 1 to 128. Clot formation should normally take place in all the test tubes. Now, if there is no clot in all the tubes, is a case of no fibrinogen in the serum. If there's no clot formation in dilution 1 to 16 onwards, it shows hypofibrinogenemia. And this is why Snyder test is important, because it gives you a picture of the level of fibrinogen in the serum. All right, different conditions can predispose to coagulation disorders in pregnancy. All right, there are specific tests that will help you to locate what specific disorder you are dealing with. In DIC, you will see raised fibrinogen degradation products, reduced fibrinogen, and you have prolonged protobate time or activated partial thromboplastin time. Now, if it's eclampsia or HEP, obviously you will have your elevated liver enzymes. All right. If it's due to any other thing like your SLE or vasculitis, you have a positive phospholipids, all right, or lupus anticoagulants. All right. Now, this is just to show you the different things that you may be able to look at, especially as relates to coagulation disorders in pregnancy. I think I've mentioned this before. I've mentioned all this. So clinical presentations actually could, like I mentioned, will either be profuse bleeding, hemorrhage, or thrombosis. Either of them can lead to catastrophic consequences. All right, hemorrhage, bleeding, spontaneous bruising, prolonged bleeding from venipuncture sites or intraarterial lines, oozing from traumatic or surgical wounds, and petechial hemorrhages, all right, can occur and may actually be the first sign of DIC setting in. We can have both microvascular or large vessel thrombosis following DIC. Microvascular thrombosis can be seen in kidneys, which may lead to acute renal failure, all right, or acute tubular necrosis. It may also actually embolize to the general cortical and brainstem system, leading to brainstem dysfunction, which can cause or precipitate impaired consciousness and coma. So management, monitor vital signs closely, all right? Monitor vital signs closely. You want to secure hemostasis as soon as possible. And blood transfusion with fresh blood or preferably fresh frozen plasma, or sometimes you may want to replace specific clotting factors. All right, so this likely exam questions I will want to talk about. Then let me see. We have acute fatty liver of pregnancy. But let's look at this question. Let me see how many of us are on this call. Okay. All right, Elizabeth, you're always the first here. All right, so look at this question. A 30-year-old multiparous woman presenting for an emergency session on account of abortion placenta develops acute DIC. I'm sure we are familiar with all of this. All right. So what are the common causes of coagulation disorders in pregnancy? Enumerate some basic coagulation studies you will order for in this patient. All right, mention 5 common causes of postpartum hemorrhage. And you want to briefly describe your intraoperative management. I'm going to give you this as an assignment. So this will be an assignment, and I want it submitted within a week. All right, instead of discussing it, let's just submit it as an assignment within a week. Is that understood?
Yes, Prof.
Okay. So one of the causes of coagulation disorders in pregnancy is the acute fatty liver of pregnancy. All right. It's an acquired disorder of unknown origin that occurs 1 in about 5,000 to 10,000 pregnancies. Acute fatty liver of pregnancy is believed to occur as a result of abnormality in the beta oxidation of fatty acids in the mitochondria. Patients with acute fatty liver pregnancies present with vague abdominal symptoms, which may include abdominal pain, jaundice, vomiting, and anorexia. And these are very unspecific. And if care is not taken, one may miss out of the diagnosis. So a high index of suspicion is required to make a diagnosis of acute fatty liver of pregnancy. All right, laboratory signs will include hyperbilirubinemia, transaminitis, elevated serum creatinine, and coagulopathy. This coagulopathy is very important too, because the earlier you pick it, the better for the patient. And it also determines the outcome, patient outcome. Outcomes of these disorders are directly related to both to the time of recognition and to the delivery of the fetus. Induction of labor or cesarean delivery is encouraged at the time of diagnosis. All right. Note that you must deliver the baby by any means, because acute fatty liver pregnancy will not resolve until delivery. All right, there have been some different opinions on the best mode of anesthesia for this patient. But studies have shown that neuralgia block has been used in patients with acute fatty liver of pregnancy. But your threshold for coagulopathy should be INR of not more than 1.5. Okay, and this is important so that you do not cause significant bleeding in a coagulopathic patient. So pregnant women on anticoagulants, all right, these days we have women with mechanical heart valves, patients who are on anticoagulants, who are falling pregnant. So with regard to unfractionated heparin, a dose less than 5,000 units twice in a day requires no further testing before you do neurasthenia anesthesia. All right. If the patient is on unfractionated heparin, all right, of less than 5,000 units BD, you do not require any testing before you can actually go ahead and give your patient neurasthenia block. But if the dose is more than 5,000 units twice a day, you need to document a normal prothrombin time before you place your epidural or you do a spinal. Platelet count also should be checked, and you need to rule out heparin-induced thrombocytopenia for patients who are on heparin. All right, if the patient has been receiving heparin for more than 4 days, you want to check your platelet counts to rule out the presence of heparin-induced thrombocytopenia. With low molecular weight heparin, all right, no testing is required, no coagulation testing is required. But remember that you need to delay citing your neurasthenia block by either 12 to 24 hours from the last injection. All right, this is where it's important. You want to find out when last did this patient have cleansing, for instance, and you want to delay. For me, I'm a shy anesthetist. I want to delay for 24 hours. All right. It doesn't matter whether the patient is receiving prophylactic or therapeutic doses. I need to emphasize this. All right. Whether sometimes the surgeon will say, but it's therapeutic. Whether it's therapeutic, it's prophylactic, whether it's prophylactic or therapeutic, it's safer to wait for 24 hours after the last injection of your cleansing before you give your spinal neurasthenia block. Another thing is that do not commence low molecular weight heparin for at least 4 hours. All right, if the patient had been on epidural catheter before you remove it. For those pregnant women who are on newer oral anticoagulants, such as the dabigatran and rivaroxaban, all right, you should delay placing an epidural catheter or even spinal for 5 to 3 days respectively, longer for dabigatran, all right? And this is for special considerations for patients, pregnant patients on anticoagulants. All right, this slide contains a lot. We have about 55 slides, but it talks about pregnancy-induced hypertension, HEP syndrome. So we're going to stop here, limit ourselves to coagulation disorder in pregnancy. I'll take some questions and some contributions. We still have about 6 minutes to go. What is the time now? We still have about 16 minutes to go. So if you have any question, any discussion points, we can quickly do that.